form of feedback, that will be great. Otherwise, it feels as though I'm just talking to thin air.
Yeah, we are here, sir. We can hear you.
We can hear you, sir.
So can you hear us?
Sir, can you hear us?
We start. I prefer if you guys can give me a feedback, because I actually don't know whether okay, I was not able to hear any of you. So have I done any CADs with you before? I have done the breast lump, no?
Yes, sir.
Yes.
Okay, can you see it now?
Yeah, we
Yes,
can see
sir.
that.
Right. So if there's anyone who is having a problem, I think I have emailed you the presentation, so they can open the presentation, and so then they can follow. Right. Okay. Shall we start?
Yes, sir.
Right. Great. Okay. So today, what we are going to discuss is about patients presenting with different types of thyroid problems. So these are the objectives. So we will broadly go through causes of thyroid enlargement, like multinodular goiters, toxic goiters, malignancies, inflammatory conditions like thyroiditis, etc. And also we will discuss the pathophysiology of various conditions. And most importantly, then we will discuss assessment of a patient who is presenting with an enlarged thyroid. We will discuss basically, very briefly, history and examination and investigations plus principles of management. So this is the most important part. Based on the pathophysiology and the investigation findings, how to decide on various types of interventions. What are the indications of intervention, and what are the types of interventions available, and the reason for selecting particular type of intervention for a particular condition. Those are things that we are going to discuss, as well as benefits and potential harmful effects or side effects of each of the treatment modalities. Right. So there are 4 different scenarios which I'm going to give you at the beginning. So very straightforward, actual patients. Pictures are the actual patient, but these scenarios are actual patients who have come to our clinic. Just think about them as you go on. You will understand what these patients are, and at the end also we can discuss. So this is a young woman, 23-year-old, maybe like you, one of you, presenting with a goiter for 6 months. In addition to the goiter, the patient has got palpitations, that is diarrhea or loose stools, a significant weight loss despite an increase in appetite or good appetite, plus irritability. So on examination, patient looks anxious. You can see this picture with a pulse rate of 120. That is, there's a tachycardia, blood pressure more or less, you can say normal even. On examination, further examination, thyroid gland is diffusely and symmetrically enlarged. It's firm and non-tender, and there's audible bruit. She has a lid lag, exophthalmos, and proptosis, quite obvious in this picture, but no periorbital edema. TSH is low, 0.001, and free thyroxine is elevated. So what is the most likely diagnosis?
Graves' disease.
Graves' disease.
Clear? Graves' disease. Yeah. So the question is, now, if you think this patient has got Graves' disease, it's a clinical diagnosis. We'll discuss that. What are the further investigations or further evaluation of this patient, and what are the options that are available for the treatment? So we will discuss that. Then a slightly different patient, a slightly older male, with a longish standing goiter. He thinks it has been there for 5 years. Again, weight loss despite an increase in appetite, sweating, palpitations over last 1 year. Examination, there's a small goiter. Both sides are enlarged. No tracheal deviation or testosterone exchange. It's a small goiter. There's a tachycardia again and hypertension. There was a lid lag, but no lid retraction or exophthalmos. TSH again, similarly low. Thyroxine levels are high. What is the most likely diagnosis?
Secondary thyroidotoxicity.
Yeah, it's a secondary thyroidotoxicosis or what you call toxic multinodular goiter. So we will discuss the differences in pathophysiology, and thereby what are the differences in investigations and management of a patient like this. Right. This lady has had a goiter for 5 years, 52-year-old, clinically euthyroid, no compressive symptoms, no rapid enlargement, no change in voice. Examination, there's a multinodular goiter involving both lobes of the thyroid. You can see right side is bigger than the left, so there is tracheal deviation to the left side. Ultrasound, it's a multinodular goiter, no suspicious nodules or enlarged cervical nodes. What is the most likely diagnosis? It's just a simple multinodular goiter, right? Probably not simple because there are tracheal deviation with some complications. So we will discuss how to manage a patient like just a multinodular goiter as well. Then these are another different patient. She has a mass on the right side of the neck, 42-year-old. No features of increase or reduced thyroid activity, but there's a solitary hard mobile nodule, 4 by 5 centimeters on the right lobe. No palpable lymphadenopathy. So essentially, she's got a solitary nodule. So what are the possibilities?
Malignancy.
Yeah, we need to exclude the possibility of this could be a benign nodule, but at the same time, this could be a malignant nodule. So in which case, we need to do the relevant investigations and manage accordingly. So just to think about the possible conditions that we may encounter. This is not an exhaustive list, but common conditions that we encounter. So as we discuss, we'll think of the relevance of these conditions or these cases to the conditions that we are going to discuss during the presentation, right? Okay. So just to brush up your knowledge, Now, this is how thyroxine production is regulated. So the function of the thyroid gland is essential to produce thyroxine. Thyroxine, we say it's a regulator of the functioning of all cells in the body. All the cells in the body, the rate of metabolism is regulated by thyroxine. That includes oxygen consumption, rate of growth, maturation. So a lot of things are regulated. So when there is a reduction in thyroxine, all these functions are reduced. At the same time, if the excessive thyroxine, all the rate of functioning of all these functions would be increased. Important thing is, now thyroxine production is stimulated or regulated by TSH. It is secreted by the anterior pituitary, you know that. So that is regulated by TRH secreted from the hypothalamus. So when based on TSH stimulation and thyroid gland secretes thyroxine, there's a negative feedback on both anterior pituitary and the hypothalamus. Thereby, the TSH secretion will be reduced, and that controls the secretion of thyroxine. So in many conditions, the conditions where there is hyper or hypothyroidism, this axis is going to be deranged. So you will find the TSH level to be elevated or reduced, and T4 and T3 levels also to be elevated or reduced. So it's important to understand that bit. Okay, so broadly, if we look at, there are several conditions or the pathologies that can affect the thyroid gland. There can be problems with function of the gland. That is hyper or hypo. Hyper is hyper functioning. We discussed that. Hypo is reduced functioning of the gland. Then we can have malignancies or just an enlargement of the gland, what we call a multinodular goiter. But the problem is multinodular goiter itself can lead to other problems like compressive effect, cosmetic effects, etc. That can also predispose to malignancies and hyperthyroidism. Then the last category of conditions are the inflammatory conditions of thyroiditis. So at any point, if you have questions, you can ask me or you can let me know whether you can hear clearly or whatever, right? I guess another thing that you need to understand, there are two things called hyperthyroidism and thyrotoxicosis. Now, hyperthyroidism is when there is overproduction of or excessive production of thyroxine from the thyroid gland, and the patient will have all the effects of excessive thyroxine in the circulation due to endogenous production of thyroxine from the gland. All conditions most of the conditions that we discussed, like Graves' disease, toxic nodular goiter, toxic nodule, whatever, will lead to increased production. Whereas thyrotoxicosis is where you have symptoms of excessive thyroxine in the circulation. It does not necessarily mean that the thyroxine is coming from the thyroid. So it could be endogenous or exogenous. Even if you take excessive amount of thyroxine, then you may become thyrotoxic, but you are not hyperthyroid. So there's a slight difference in the terminology. Similarly, in thyroiditis, there is no increase in production. It is just a destruction of the gland leading to excessive release of thyroxine. So again, there is no hyperthyroidism in thyroiditis, at least according to the definition. Remember that. So the standard symptoms of hyperthyroidism, these are fairly straightforward. So I will quickly rush through these slides. So the most specific symptom would be weight loss despite an increase in appetite. There are hardly any other conditions where there would be any weight loss with an increase in appetite. Only other potential condition is diabetes. Due to glycosuria, there can be a reduction in weight despite an increase in appetite. But every other condition, always the weight loss is associated with a reduction in appetite. Other symptoms include hyperactivity, irritability, heat intolerance, palpitations, fatigue, diarrhea, polyuria, oligomenorrhea. So there are a lot of other symptoms, but they are not very specific. You can have all these symptoms due to various other conditions, and these are, remember, very subjective symptoms as well. Most people do feel sleepy. Now, even some of you might be feeling sleepy. That doesn't mean that you are hyper or hypothyroid. Right? Whereas weight loss is a fairly objective symptom with an increase in appetite. That is the most specific symptom in relation to hyperthyroidism. So signs of hyperthyroidism includes tachycardia. Older patients may present with atrial fibrillation, hypertension, typically a systolic hypertension. I think we probably would have discussed during the appointment the reason for systolic hypertension. There is increase in cardiac output, secondary to increased chronotropic and inotropic action on the heart, whereas there's a reduction in peripheral resistance due to peripheral vasodilatation due to both beta-adrenergic action and muscle vascular dilatation. Therefore, there's a reduction in diastolic blood pressure. So typically what they have is systolic hypertension. Also, they may get tremors, warm, moist skin, proximal muscle weakness, lip retraction, gynecomastia. There are so many other signs that you may see in these patients. Right. So, again, when somebody comes to the enlargement of thyroid, morphologically, we can divide into, classify them using different methods. So, for example, we can say it's a simple goiter, toxic goiter, neoplastic based on the primary underlying pathology or inflammatory goiter or thyroiditis goiter, etc. Then WHO, there is a classification based on the size of the nodule enlargement. So, for example, G0 or G0 is no goiter, G1 is when it is visible, G2 is visible without neck extension, G3 is visible from a distance. So in your cases, even it may be useful to mention the WHO categorization of the size of the thyroid. Then third category is a more important one for us, where you define the enlargement of the thyroid based on its nodularity. Whether there's a single nodule in an otherwise normal gland, single enlarged nodule or a palpable nodule in an enlarged gland, or when there is more than single palpable nodule, where you could call it a multinodular goiter. So this is something that we expect you to know, the differences among solitary nodules, dominant nodules, and multinodular goiters. At the end of your short case examination, we expect you to come up with this morphological classification and tell us whether it's a single nodule in a normal gland or what you call a solitary nodule, single palpable nodule in an enlarged gland, that is a dominant nodule, or whether it is a multinodular goiter. Right. So then we will discuss toxic goiters. There are commonly three types of hyperthyroid goiters, that is Graves' disease, toxic multinodular goiters, and toxic nodules. Plus thyroiditis, you can get toxicity, but actually there is no hyperthyroidism. So we'll start off with Graves' disease. So Graves' disease is a fairly common condition. In Western countries, it's the commonest cause of hyperthyroidism. For some reason, it is not so common in Sri Lanka, and secondary toxicosis is anyway much commoner in Sri Lanka due to high incidence of multinodular goiters, which we will discuss later. So it's an autoimmune disorder. There are antibodies produced against the TSH receptor, which stimulate this receptor. Generally, we know antibodies, what they do is they go and block the receptor. But this particular antibody, what it does is through the process called molecular mimicry, it stimulates TSH when it binds to the TSH receptor. So there is increasing activity, increased production of thyroxine despite a very low TSH in these patients. Because antibody is what is stimulating the TSH receptor. Even in the absence of TSH, there will be excessive production of thyroxine. So other features of Graves' disease include it could be associated with other autoimmune conditions, because you know some autoimmune conditions go together. Plus, there could be other manifestations due to this production of autoantibodies. For example, some of the eye signs you get due to the production of these autoantibodies. So some of the eye signs you will find only in Graves' disease, whereas other eye signs you will see in other conditions of hyperthyroidism, that is secondary toxicosis and solitary toxic nodules. Right. So in Graves' disease, there are in hyperthyroidism you get several eye signs. You need to know what exactly these eye signs are, how to elicit them, and the definitions. Right. For example, exophthalmos. Exophthalmos is, you can see the first picture. This lady has exophthalmos. Exophthalmos is when you can see sclera below the cornea. In a normal person, generally you will not be able to see any amount of sclera below the cornea. It will be covered. But if you can see more than 2 millimeters, that is called exophthalmos. But if you read American books, sometimes it is used interchangeably with proptosis. But in British books, it's clearly defined as sclera below the cornea. Ophthalmoplegia is when there is weakness of the extraocular muscles. Proptosis is bulging of the eyeball. It happens due to the edema of retroorbital muscles. Chemosis is conjunctival injection, as you can see here. Lid lag and lid retraction are due to excessive sympathetic activity on the levator palpebrae superioris muscle. So it is not specific to Graves' disease. Any condition, any patient with thyrotoxicosis may have these physical signs, that is lid lag and lid retraction. Whereas the first two physical signs will only be seen in patients with Graves' disease, because they are mostly related to the autoimmune activity. So pathophysiology, again, just going through the eye sign pathophysiology. So increased sympathetic tone, eyelid muscle, that is the reason for lid lag and lid retraction. Exophthalmos and proptosis due to extraocular muscle edema and deposition of polysaccharides and edema fluid. Ophthalmoplegia is weakness of extraocular muscles. There is fibrosis and restricted mobility. And rarely they can, very severe disease, there can be increased pressure on the optic nerve and leading to optic nerve palsy and corneal ulceration. Chemosis is edema due to exudation. Okay, then there are a few other manifestations. These are, of course, very, very, very rare. Very rarely only you will see maybe less than 1 in 100. For example, pretibial myxedema. You can see some thickening of the skin over the tibia. Then you can have thyroid ectobrachy, which is pretty much similar to clubbing. And the third is what you call onycholysis, that is spontaneous separation of the nail of the nail plate. Remember, these are very, very rare signs, and you will not see every day in all patients with Graves' disease. Right. So let's say now a patient has come with we'll go back to the first girl, 23-year-old girl who has come with features of Graves' disease. Now we think we have made a clinical diagnosis of Graves' disease. Can somebody tell me what investigations we should do in this patient and why? Just think for a couple minutes and then let me know the answer. Okay, are you guys there or sleeping? Can you hear me? And can any of you hear me?
I can hear you, sir.
Right. Okay. So can somebody answer my question? What are the investigations you do on a patient who comes with features of Graves' disease? Okay, you don't want to answer, right? Let's go. Okay, so it's mainly a clinical diagnosis. That particular patient, you're absolutely sure the patient has got Graves' disease. Not all the time, but in most situations, we can clinically diagnose Graves' disease. But we do some investigations to confirm the diagnosis and to assess the severity and then response to treatment. So the basic investigations include a TSH and a free T4 plus or minus T3 level. So you expect the T4 level, TSH level to be very low, like the patient I gave you at the beginning, and the free T4 levels to be high. Typically in Graves' disease, T4 levels are quite high. Then the specific investigation would be TSH receptor antibodies. But it is not an investigation that is absolutely necessary in the management of patients with Graves' disease. Another thing is it is not freely available, certainly not available in the hospital. It's available only in the private sector and it's quite expensive. It costs about 10,000 rupees. Therefore, we don't routinely do it because it doesn't change our management. But there are certain situations where there is difficulty in diagnosis, where we are not sure of the diagnosis, then that is a clear indication for doing thyroid receptor antibodies. Otherwise, we routinely don't do it. But at the same time, the thinking pattern is changing a little bit. People think that antibody titer is related to response to medical therapy. So some people now do it routinely, but certainly not in our practice yet. So scintigraphy is another potential investigation, but it's not essential. Again, not necessary. I would say not necessary in Graves' disease because with the investigation that we have discussed, we can make a diagnosis. And scintigraphy certainly is not going to change the management in patients with Graves' disease. Okay, so how should we manage a patient with Graves' disease once the diagnosis is confirmed? So the primary treatment is to reduce the production of thyroxine from the gland. So the problem here is there is excessive production of thyroxine from the gland. We want to do something to reduce or control or stop the production of thyroxine from the gland. That is the first category of treatments. Then in certain situations, until that treatment works, which may take some time, we can start the patient on symptomatic treatments. The important thing for these symptomatic treatments is that they act quite quickly. So within a day or two, patients' symptoms are going to improve. Then the third category of treatments are to manage complications. Some patients do have complications due to various problems, and we may do additional treatments to manage these complications. So going back to the first one, so antithyroid drugs is the cornerstone of treatment of Graves' disease. There are two standard medications, propyltyrosol and carbimazole. Out of these two, carbimazole is the first line treatment for Graves' disease in most situations. In addition to medical therapy, we have a couple of other treatments that includes radioiodine therapy, and then we can offer them surgery as well, that is in the form of a thyroidectomy. We'll discuss these things in later slides. So there are other treatments, including, for example, steroids, lithium carbonate. All these can be used to reduce the production of thyroxine from the gland, but they are second-line treatments. Then for symptomatic treatment, we are trying to achieve a rapid control of symptoms. So standard is to use a non-selective beta blocker like propranolol, or we can use steroids for the same effect. In complications, we discussed some of the patients may have severe proptosis, whereby they can't close the eye. So when they can't close the eye tends to get dry, and then the cornea can get ulcerated. In such patients, what we do is we can suture the eyelids together, or what we call lateral tarsography. Or else in some patients, very severe, we may have to do a decompression, orbital decompression, or orbital radiotherapy, or radiotherapy to the orbit are the standard treatments to manage these complications. Right, so medical management. So antithyroid drugs are the first line therapy. So why do we start antithyroid medications? Because before we do even surgery or radioactive iodine therapy, unless the patient is controlled, patient's thyroid status is controlled, there is a higher risk of developing complications. So whatever it is, first line treatment is to start them on medications. So we start with the antithyroid drug, typically carbimazole. In addition to that, now the action of carbimazole is it reduces the uptake and organification of iodine inside the thyroid follicular cell. In addition to that, it has what you call a immunomodulatory action. So it not only controls hyperthyroidism, it changes the autoimmunity. Therefore, in about 40% of the patients, Graves is cured with antithyroid medications only. So therefore, that is why it is a first-line treatment. However, in a substantial proportion, although the disease is controlled, once you stop medication, the disease can come back, or what you call the disease can relapse after discontinuation of the medication. So how long should we give carbimazole? Standard is to give for a minimum of 6 months and a maximum of 18 months. So if the patient's disease is not cured with 18 months of treatment, then it is very unlikely the disease will be cured. So disease may be controlled with carbimazole, but disease is very unlikely to be cured by continuing carbimazole any longer. So how do we give carbamazole? Standard dose is to start, standard method is to start with a high dose. So what we start is maybe 15 milligrams 3 times daily or 20 milligrams 3 times daily. That is 45 to 50, 60 milligrams. And then gradually, depending on the patient's response, we titrate and reduce the dose. And the typical maintenance dose is about 5 milligrams once daily. So it's fairly easy for the patient to take that single dose once daily. Block and replacement is another option. Here we give large doses, continuously give large doses of carbamazole, but when the patient becomes hypothyroid, we start replacing thyroxine. It is more complicated, more difficult, and greater risk of side effects, etc. Therefore, it has kind of gone out of fashion now. We don't use it anymore. Right. So this table shows the different types of treatment modalities that are available for the treatment of hyperthyroidism. So carbamazole is the first one. It inhibits the production of thyroid hormones or the synthesis. So the indication, it's the initial treatment. Similarly, propylthyroxine. Only difference between carbamazole and propylthyroxine is propylthyroxine additional to the reduction synthesis causes reduction in conversion of T3 to T4 in the peripheral tissues. T3, as you know, is more active than T4 levels. T4, therefore, it helps to reduce the action further. So the side effects include agranulocytosis, that's the most significant side effect, but fortunately again it's quite rare, maybe 1 or 2 in 1,000. So not a very common side effects. Others include hepatic necrosis, cholestasis, etc. Now carbamazole cannot be given during pregnancy, whereas propylthyroxine is the preferred treatment during pregnancy. However, propylthyroxine, if you are using it, you have to use it very carefully because risk of hepatic side effects are quite high with propylthyroxine compared to carbamazole. That is why we don't use propylthyroxine that commonly. So only during pregnancy or in patients with thyroid stones, we use propylthyroxine. Otherwise, carbamazole is a standard treatment. Then we have beta blockers, that is to control the symptoms initially, maybe over the first couple of weeks to a month. Only thing that you have to be careful of, you can't use beta blockers in patients with asthma or COPD because that could be even more serious than controlling the side effects of or the effects of hyperthyroidism. Then we have glucocorticoids like prednisolone or hydrocortisone. What it does is it again reduces the peripheral conversion and reduces the peripheral receptor sensitivity. So in certain situations where we cannot control the patient's hyperthyroid status with other medications, we can use glucocorticoids. But of course, it has to be short term. We are not supposed to use long-term steroids because the side effects again can be quite severe. Then the last category of treatment, fifth category, is what you call leukocytin or supersaturated potassium iodine. Here, if you remember your physiology, which I doubt, there's a thing called Wolff-Chaikoff effect. That is when you give large doses of iodine to a patient or a person, there will be short-term reduction in the production of thyroxine from the gland. But if you give it over long-term, which you call Jod-Westow phenomenon, there will be a rebound increase in the production. So leukocytin or saturated potassium iodine can be used as a short-term measure to reduce the production of thyroxine from the thyroid. So we use it in patients again with thyroid stone or in patients with patients before undergoing surgery if the patient's thyroid status is not controlled. Right. Then after the medical therapy, we come into radioiodine therapy. Here what we do is we give a radioactive isotope of iodine. So you know iodine is selectively taken up by the thyroid. So this is taken orally, so it gets absorbed and then thyroid concentrates its radioactive iodine. So what the radioactivity does is it damages the thyroid follicular cells. So if the gland is hyperactive, radioactive iodine will be taken up by these hyperactive cells and there will be a destruction of the gland. So radiation-induced thyroid destruction controls the hyperthyroidism. So it is indicated in patients with Graves' disease who are not cured with medication. Then as a second line definitive treatment option, we can use radioactive iodine. Right. So advantage is if you use radioactive iodine as compared to surgery. Now, if the patient does not respond to medications or if the patient is not cured with medications alone in Graves' disease, we have two second line treatment, that is surgery and radioactive iodine therapy. The advantage of radioactive iodine therapy is you are avoiding an operation. And if you can control the patient's hyperthyroidism and make the patient euthyroid, you avoid the need for thyroxine as well, in addition to avoiding an operation. But unfortunately, over long term, the majority of the patients who are given radioactive iodine therapy become hypothyroid because there's a progressive destruction of the thyroid. Therefore, what we say is over 10 to 20 years, about 80% of the patients who have received radioactive iodine will become hypothyroid. Right. So there are some side effects of radiation. Of course, there can be radiation thyroiditis, silanitis, etc. And the other thing is it is potentially teratogenic. So we have to avoid radioactive iodine if the patient is pregnant. And any woman who is given radioactive iodine should not get pregnant for at least 6 months, ideally for 1 year. So they need to use contraception during this period. Surgeries are the option. What we do is what you call a total thyroidectomy, where we remove the whole gland. So we start again going back. When a patient with Graves' disease comes, we start them with medications. So if the disease is cured, that's the end of the story. But if the disease is not cured, they are dependent on medications, then we can go for either radioactive iodine or surgery. So surgery, if you're going to go for surgery, it's going to be a total thyroidectomy. Advantage is, so once you remove the whole gland, the disease is completely cured. There is immediate definitive treatment. But the disadvantages include it's an operation, so the surgical complications are a problem, like recurrent laryngeal nerve palsy, hypocalcemia, or hypoparathyroidism. These are some side effects. Plus, definitely they will have to be on lifelong thyroxine therapy. Although there's definitive cure of the condition, there will be sequelae, which are probably more than with radioactive iodine therapy. So these are the standard complications that we discuss. Recurrent laryngeal nerve palsy, it is about 1%, hypoparathyroidism, permanent 2 to 3%. So plus excessive bleeding and thyroid storm. Luckily, these are very rare conditions. With good preoperative preparation, we can minimize this bleeding and thyroid storm. So ideally, you should not see these two complications. Right. So since we are discussing the potential of thyroid crisis or thyroid storm, we'll discuss briefly. So what is it? It's an abrupt, life-threatening form of hyperthyroidism. It typically happens in a patient with hyperthyroidism due to an additional insult. So with this additional insult, there is a rapid or excessive release of thyroxine into the circulation. So some of the causes include infections. So a patient with uncontrolled hyperthyroidism, even with respiratory tract infection, a thyroid storm may be precipitated. Or surgery is another one. It could be thyroid surgery or surgery elsewhere in the body. Any stressful situation, trauma, all these are potential situations where the patient may develop a thyroid crisis or thyroid storm. How do they manifest? They will go in due to excessive thyroxine, massive doses of thyroxine being released, they go into a hypercatabolic state. Patient becomes severely hyperthermic, tachycardic, and they can also develop cardiac arrhythmias. They may also get chest pain because cardiac ischemia due to severe tachycardia, and they can also become dyspneic. Vomiting, restless, agitation, delirium, all these are symptoms of a thyroid storm. So the confirmation, we need to do urgent T3 and T4 level to confirm. Of course, there's no point in doing TSH. TSH is going to be normal in these patients because this is an acute onset problem. So management, we need to give them antithyroid drugs, that is carbimazole. Then we can give some iodide, ideally intravenous, we can give sodium iodide. We discussed like the action is similar to giving logocydin. Large doses of iodine reduces the release of iodine thyroxine from the gland. Plus, we can give large doses of beta blockers, non-selective beta blockers to reduce the peripheral cardiovascular effects. Hydrocortisone for the similar effect, it reduces peripheral conversion and reduces peripheral receptor sensitivity. Plus, the patients will need additional supporting measures like IV fluids, cooling of the body. You can use cooling blankets, ice, NG lavages, air-conditioned room, fan. And to deal with the hypercatabolic state, they need to be on oxygen because the body has gone into catabolic state. And unless you give oxygen, they can become hypoxic. Right. So that's about the management of Graves' disease and the potential complications. So just to summarize again, Graves' disease is a clinical diagnosis. Most of the time, the investigation that you would require is only T4, TSH level. Based on that, only we can manage. But if there's a doubt, you can do thyroid receptor antibody levels. Then the management is primarily starting them on medications. We start them on carbimazole plus or minus propranolol depending on the severity of symptoms. And starting off with high doses, gradually we titrate the dose of carbimazole and maintain the maintenance dose of carbimazole to a minimum of 6 months or up to a maximum of 18 months. Then we can stop the medications and see whether the disease comes back. If the disease comes back, then we need to restart, and once the disease is controlled, we need to go for definitive treatment, a second line definitive treatment that includes either radioactive iodine or surgery. So we discuss advantages and disadvantages of surgery versus radioactivity as a second line definitive treatment modality for Graves' disease. And one of the complications we discussed, thyroid crisis or thyroid storm. Right. So before we go into next one, are there any questions?
Sir, why we commence with a very high dose of carbimazole in treating Graves' disease?
Okay, so the control, the time that takes for the control of hyperthyroidism depends on the dose of the drug. So when you start off with a large dose, you can achieve a rapid control. Now here, in addition to achieving control, we give propranolol because we want to ensure the patient's clinical symptoms as well as other effects, because there are so many harmful effects due to hyperthyroidism. All those are controlled as early as possible. That is why we start off with a large dose or what we call low dose or a maximum dose. And as the symptoms are controlled, what we do is we gradually reduce the dose to a maintenance, which minimum maintenance is generally 5 or 10 milligrams once daily. That is enough to maintain euthyroid status in these patients once the disease is controlled. Initially, if you start off with 5 or 10 milligrams, it might take months and months for the patient to achieve the control. So that is not the desired effect. We want the patient to be controlled as soon as possible. Even when you start on the maximum dose, it still might take a couple of months for the patient to achieve control. Right? That is why we cover the initial period with propranolol. Any other questions?
So, is there a place for imaging in Graves' disease?
Okay, again think. Why do you want to image and what imaging modalities are you thinking of? So are you thinking of ultrasound scan?
Yes, sir.
Okay, so what will you see? You will see a uniformly enlarged gland. So now, should we now think, are you expecting this particular patient to have a malignancy or a nodule or whatever?
No.
No. So it is like the normal general population. Should we be doing scans on normal people? Probably no. But of course, a normal person can also have a nodule which is malignant. But are we going to do routine scans on all people? No. It's same here. Patient has come with a condition which does not require imaging or where the imaging does not change the management. So therefore, there is no place for a routine scan in a patient with Graves' disease. Unless there's a specific reason. If you have a nodule that you can feel or some other reason, then you can do a scan. But otherwise, there is no place for doing an ultrasound scan in a patient with Graves' disease. It's just a biochemical assays only. Good question. Any other questions?
Thank you, sir.
So are there instances in which we go for the surgery as the first line in Graves' treatments?
Okay, so if you think of the indications where we would do surgery, so indications of thyroidectomy is, of course, if the, I think we are coming back to that in a different slide, we discussed when the oral medications fail to cure the disease. But in other situations where there are potential situations where carbimazole might not control the disease even, or what you call drug-resistant hyperthyroidism or Graves' disease. Carbimazole might not control the disease even, not leave alone cure, it might not control. Then we have to straight away go for a second-line treatment. And pregnancy. Now, pregnancy we discussed, carbimazole cannot be given, only propylthiouracil can be given. But propylthiouracil may have significant side effects. Anyway, pregnancy they will have polystasis. So propylthiouracil can further exacerbate. So any side effects to medication, that is another indication for surgery. Severe eye disease. That is not a common thing, fortunately. Patients with severe eye disease, what we know is either medication or radioactive iodine is not going to be that effective. So surgery is the most effective treatment in a patient with severe eye disease. So there are so many other situations where we may have to do surgery early without waiting for 1.5 years or 2 years of carbimazole treatment. Did I answer your question?
Yes, sir. Thank you.
Any other questions? Are there any other questions on management of Graves' disease?
So, in the initial investigation, do we do both all the TSH, free T4 and free T3 all three together, or is there a place to doing TSH and T4 first and then?
It is like this. Generally, TSH and T4 alone are enough. Anyway, that is what is done in the hospital. T3 is generally not very helpful in the management. So only absolute indication for doing a T3 level is if you are suspecting T3 toxicosis, because you know T3 has no negative feedback effect on the hypothalamus or the pituitary. Okay, so rarely you may find a patient who is toxic clinically, but TSH and T4 levels are normal. So in such patients, T3 level is what you need to do, but it's a very rare condition of what you call T3 toxicosis. It's a rare condition. So as a routine, it is not essential that you do T3 levels.
Thank you, sir.
So another thing, just continue on with eye signs. Patients with severe eye signs, I discussed about treatment. One thing, you can give radiotherapy, orbital decompression, and methylprednisolone and pulses. In medical wards, you might have seen those patients are given pulses of methylprednisolone to suppress the immunity, because that also has been shown to reduce the effects on the eye. Then otherwise, early surgery is the other option. Okay.
So there's a question on the chat.
Yes, one person, please. Yeah.
So there's a question on the chat, sir.
Chat. Okay. There are two chats. Is there an emergence of RAI as a first-line treatment if Graves is in other countries? If there is, what is the reason? Sir, can we give antithyroid drugs for relapse of Graves? Right. Okay. So let's say now I will answer the easy question first. Antithyroid drugs in relapse. So let's say somebody started on antithyroid drugs. You let's say continue for 18 months, then you stop the medications. So then the patient gets a relapse. Of course, we have to go for medication. We know the medication is going to control the disease, but it is not going to cure. That is the difference. So we start on medications, then we don't stop the medication, but straight away we go for a second-line definitive treatment without stopping the medications again. So it's fairly simple. Right. Then the second question is whether there's an emergence of radioactive iodine therapy as a treatment modality. It depends on the country and the availability of radioactive iodine. Now, radioactive iodine is produced as a byproduct of these nuclear reactors. So it is available, freely available, rather only in countries where nuclear reactors are readily available. You know, in Sri Lanka, we do not. So radioactive iodine for Sri Lanka, this is out of the context, I'm just telling you the reasons. we need to get it from Europe. Essentially, we are getting from Eastern Europe, getting from a country like Belarus. So it has a very short half-life, few days. So we get our radioactive iodine in a flight every week to our country. So there are very difficult logistics when it comes to radioactive iodine, and then after giving radioactive iodine, patient has to be isolated. Therefore, giving radioactive iodine is not a very simple treatment modality, although it may sound, because it's just a single capsule. And the cost. So there are a lot of logistical reasons or difficulties associated with giving radioactive iodine. Therefore, in Sri Lanka, we don't generally prefer to give radioactive iodine. But in other countries, for example, in Europe, that is one of the first line treatments. So they prefer to give radioactive iodine. Whereas in US, they always prefer to do thyroidectomy early. There are situations where what they do is, in most situations, start the patient on medications and go for early thyroidectomy without waiting for 6 months or 18 months. So all these are options, but I don't think it is very important for you. Right? Any other questions? Okay, there are more questions on the chat. Significant risk of triggering malignancy. Graves, and how do we need to monitor? Okay, so once you start the patient on carbimazole, one of the side effects that you are worried about is agranulocytosis. So ideally, you need to tell the patient that if they develop a sore throat or something, they need to come and see you. And ideally, again, you need to do a full blood count a couple of weeks after starting carbimazole to look at the white cell count. But routinely, we don't do it because we know the risk of getting agranulocytosis is quite rare, maybe 1 or 2 in 1,000. So it may not be cost effective in doing that. The risk of malignancy, yes. Of course, there's a risk of malignancy, but it is not very high because the amount of radiation that we use is not that great, and the radiation effect is only on the thyroid. Of course, we have a long-term risk of developing radiation-induced thyroid malignancies, but at the same time, we need to cure the current condition. So it's a risk versus benefit. Of course, there's a marginal risk of developing future malignancy. Will there be a change in the size, goiter size with antithyroid drugs? That is one question. Answer is no. There won't be a significant reduction in size. In fact, after starting on carbimazole, there can be transient increase in size. So that is something we need to warn the patient about, that after starting the patient on carbimazole, over the first couple of months, the size of the goiter can go up. Then, is there a possibility of continuing antithyroid treatment long term without? Okay. So to answer that question, okay, there is one question even patients ask. Because we know after thyroidectomy or radioactive iodine therapy, most patients anyway end up with lifelong thyroxine. So they want to know whether there's a possibility of continuing lifelong carbimazole. Generally, that is not recommended because what we know is carbimazole has a limited action. So after a certain time period, after a few years, patients have a high risk of developing carbimazole resistance. So if they develop carbimazole resistance, then the only option we have to control the patient prior to surgery or radioactive iodine therapy even may be lost. Therefore, we generally do not recommend that unless a patient is not suitable for surgery or radioactive iodine therapy, maybe in a very old patient who has only a couple of years to live. Eye signs specific to Graves after treatment. Okay, some of the eye signs will improve, especially if the autoimmune condition is also controlled, then the retroorbital edema, etc. will improve, but most of the time, eye signs will remain lifelong. There will not be a complete resolution of eye signs even when the disease is completely cured. So you need to tell the patient, okay, your eyes will still be bulging, but it's going to get better in most situations. Can we go for option? Yeah. So that is an option. Let's say somebody comes with a big Graves goiter, but typically still Graves disease, the goiter is posed due to hyperthyroidism. When the hyperthyroidism is controlled, size of the goiter may go down a little bit, but not completely. So if the patient has a big goiter, surgery can be considered early. Definitely yes. Any other questions?
So how often do we need to do a thyroid profile while the patient is on antithyroid?
Right. So once you start the patient on carbimazole, we need to monitor their response. So we start them on carbimazole plus or minus propranolol, and generally we see them, unless they are very, very symptomatic and have serious problems, we routinely see them in about 6 weeks' time. Because what we know is for the thyroid function test to change and for the action of the carbimazole, it takes minimum of 6 weeks to few months. So there's no point in seeing them earlier than that, unless the patient has got serious other complications. Let's say patient is an atrial fibrillation, other cardiac complications, then we may see the patient more frequently to assess those complications. But from the thyroid point of view, seeing them after 6 weeks is more than enough. With a repeat T4 TSH. Anyway, we know TSH will not be changed prior to that. Minimum time period taken for TSH change is 6 weeks. So generally we see them in about 6 weeks to 2 months time. Okay, good. Any other questions? Right, good. So we'll go into the next topic, that is toxic multinodular goiters. Right. So what happens in a toxic multinodular goiter is, this is a This typically occurs in a long-standing multinodular goiter. When the multinodular goiter has been there for a long time, what can happen is there can be variable growth of individual nodules due to various insults. And there will be what is hemorrhage, degeneration, followed by healing, fibrosis. So there are repeated episodes of proliferation and regression or necrosis. So during this process, some of the follicular cells may become autonomous. That is, they are no longer under the control of TSH. Now we discussed generally normal thyroid is under the control of TSH. So if there is increased production, there will be reduced TSH, thereby the production will be reduced. But here the cells become autonomous. So when the cells are autonomous, there will be increased secretion despite low TSH levels. So what we say is about 10% of multinodular goiters do become toxic at some point. So you can see the incidence of toxic multinodular goiter is directly related to incidence of multinodular goiters. In Sri Lanka, about 6% of the adults have multinodular goiters. So that is why in Sri Lanka, this is the commonest cause of hyperthyroidism. A significant proportion of people become hyperthyroid with toxic multinodular goiters, which is much more than patients with Graves' disease in Sri Lanka. So the presentation, typically these are patients who have had a goiter going on for a long period. And in addition to that, they will have features of hyperthyroidism. But remember, these patients, the severity of hyperthyroidism is less and the manifestations are also quite less. For example, weight loss and appetite may not be seen in these patients. Sometimes the only thing that they present with is heart failure or atrial fibrillation, much more than the symptoms that you see in young people. And there's another thing called apathetic hyperthyroidism. We know this is a condition that you see in slightly older people. Sometimes it's a total opposite symptoms that you see. They become very lethargic, sleepy, despite the patient being hyperthyroid. So in an older patient, you can get this phenomenon of what you call apathetic hyperthyroidism. Hyperthyroidism manifests with features of hypothyroidism. Right. So what are the investigations? Like Graves' disease, we do a TSH level that will confirm the patient is hyperthyroid. T4 level, it will tell us the severity of the hyperthyroidism. Here we do ultrasound scan because we know this is a patient with a nodular goiter. Unlike in Graves' disease where they get a uniform or a diffuse goiter. Because we want to assess the status of the nodules because there could be a malignant nodule in this particular patient with a multinodular goiter. So if we do FNAC, only if we see a suspicious nodule or the biggest nodule can be sampled. So uptake scan again is not going to be useful in these patients. So how do we treat? Here again we start the patient on antithyroid medication, pretty much like Graves' disease, plus or minus propranolol. And we see them in a couple of months' time, then gradually reduce the dose of carbimazole, and take them to the regular maintenance of carbimazole. But what we know here is it is not an autoimmune condition. So carbimazole itself is not going to cure the condition. It is only going to control hyperthyroidism. The moment we stop carbimazole, disease is going to come back. So there is no point in trying it for 6 months or 18 months or whatever. Here what we do is we straight away go for a definitive treatment. That is either surgery or radioactive iodine therapy. So initially we control medically, then we go for definitive treatment. So surgery, most situations we go for surgery for several reasons. Here this is a patient with a multinodular goiter. So goiter size we know is not going to go down with radioactive iodine that much. Only there will be minimum reduction because one of the reasons is most of the nodules are not active. They are colloid field nodules. So radioactive iodine is not going to reduce the size of these inactive colloid field nodules. So the goiter size is going to remain, especially if the patient has got retrosternal extension, tracheal deviation, then there's no point in going for radioactive iodine therapy because those things are not going to be changed. So radioactive iodine therapy is good to control hyperthyroidism. So in a patient with a small goiter, it may be useful, but not in a patient with a big goiter because the size will not go down significantly. And other differences are the same like for Graves' disease. Right. So toxic multinodular goiter, are there any questions?
So is there a time period the patient should be on antithyroid medications prior to surgery?
There is no definite time period. We generally, it takes a couple of months for the patient to be controlled. So what we do is we start them on antithyroid medications. We relieve them with repeat T4 TSH in a couple of months' time. And once they are controlled, we reduce the dose and then we go ahead with surgery. We don't wait for 6 months or 18 months, unlike in Graves' disease. So as soon as the patient is controlled, we can go ahead with surgery. Any other questions?
Sir, if the patient can undergo the surgery immediately, then is there a point in giving carbimazole like antithyroid drugs that can we manage him with propranolol like drugs and immediately go for surgery?
This is a patient with toxic multinodular goiter. So the patient is toxic. So we know if we operate on a patient who is toxic and not controlled, there's a high risk of patient developing a thyroid storm or a thyroid crisis. So therefore, it is a must that we start the patient on carbimazole. So we start the patient on antithyroid drug, then we go ahead and do the surgery. Okay. There could be exceptions. Let's say, for the example, patient develops serious side effects due to carbimazole, like granulocytosis. Then we can't continue carbimazole, or patient is resistant to carbimazole for some reason. Then we may have to operate in an uncontrolled patient. So then what we do is we start the patient on propranolol, steroids, leucocytin, and cover, and then we operate. Okay, did I answer your question?
Yes, sir. Yes, thank you.
Any other questions? Okay, so there's a question on malignant transformation and toxic multinodular goiter. So toxicity is not a risk factor for development of malignancy, but what we know is in about 10% of the multinodular goiters, there could be malignant foci. That's a well-known thing. So otherwise, toxicity is not a risk factor for development of malignancy, whereas multinodular goiters is. Okay, so in toxic multinodular goiters, question is whether we can do only one lobe if only one lobe is involved. So how do we know that if only one lobe is involved? This is a patient with a multinodular goiter. So for us to know whether it's only a single lobe, we'll have to do a radioisotope scan. So if the isotope scan shows an uptake only in one side, there is potential for us to remove that side only. But most situations, it is just that other side is suppressed more than the side that is active. So even after removal of one side, most likely the patient will come back in a couple of years' time with recurrence of the disease because of the opposite side. So therefore, in general, almost always you do a total thyroidectomy in a patient with toxic multinodular goiter if you are going to go ahead with surgery. Any other questions? Right. So if there are no questions, we'll move into next topic, toxic nodule or toxic adenoma. So here what happens is there is a adenoma in the thyroid, or a single nodule which is producing thyroxine. So it's an autonomously thyroxine producing adenoma causing hyperthyroidism. So that again the presentation is typical. They will come with features of hyperthyroidism. Age could be variable, again more common in females. Investigations include TSH, the T4 level. Ultrasound scan will confirm the fact that there is only a single nodule. Unlike in a toxic multinodular goiter where there are multiple nodules, here there will only be a single nodule. We may do a FNAC depending on ultrasound findings, but it is not a mandatory thing because we know when there's hyperthyroidism, risk of malignancy is very low. So, but important thing is this is the only definitive indication for doing a thyroid uptake scan, because without the uptake scan, we can't clearly plan further management. So here what we do is we give technetium-99 colloid to this patient, which is taken up by the thyroid. So you can see the patient has a nodule over the left lower pole, and isotope scan shows a hot nodule over the relevant area. So then we know this is a solitary toxic nodule. Otherwise, this patient's hyperthyroidism could be due to increased production from rest of the gland. We don't know that. Only this investigation will confirm that this is the nodule that is producing thyroxine. So for this patient, if we do a left lobectomy or left hemithyroidectomy, then the patient is going to be cured. So it is important, especially if you are planning on surgery. For radioactive iodine, of course, it will not be that useful, but surgery, it's a must that we do this radioisotope scan prior to surgery, because then we can do only remove half of the thyroid and patient is going to be cured for life. Right. So toxic nodule radioiodine we can use. Generally, these patients have a much lower risk of hypothyroidism because it's only a single area that is hyperactive, and radioactivity is taken up by that area and not much by the rest of the gland. So rest of the gland essentially is protected from the radioactivity because the nodule takes up all the radioactivity. Surgery, if you are going to do, it's going to be ipsilateral lobectomy or hemithyroidectomy. We are going to leave the opposite side so that avoids the need for long-term thyroxine, and the surgical complications are also reduced. Right. Any questions? So we discussed 3 conditions causing hyperthyroidism: Graves' disease, toxic multinodular goiters, and the toxic adenoma. So any questions on any of those 3 conditions?
Sir, is there a place for antithyroid drugs using for management of toxic nodule?
Yeah, again, any patient with toxicosis, primary management is medication. So Graves' disease, we start them on medications and 40% will be cured. Only 60% will require secondary treatment. Secondary toxicosis or toxic multinodular goiter, we start them on medication. 100% will require a second line medication. That is a surgery or radioactive iodine therapy. Toxic nodule, it's the same. We start them on medication. 100% will require surgery or radioactive iodine therapy to deal with the adenoma. Okay. So that's a question. Secondary hyperthyroidism always due to multinodular goiters. Yes. Toxic multinodular goiters and secondary toxicosis or Plummer's disease all are synonyms. They describe the same condition, the same pathophysiology. So a patient cannot develop secondary toxicosis without having a multinodular goiter. There's another condition. What would be the FNA in a toxic adenoma? It is just normal thyroid follicular cells. That's all. It's going to be Thy2 if we do it. So that is the reason why we don't do it. Because typically malignant nodules are there are exceptions, but typically malignant nodules are not producing thyroxine. Right. Okay. Next topic, multinodular goiters. So we discussed previously also, I told you about 6% of Sri Lankan adults who have multinodular goiters. So it's a very common problem. So we are essentially endemic. Sri Lanka is an endemic country for multinodular goiters, but of course we occasionally get sporadic and familial goiters as well. Like all other thyroid conditions, it is common in females. So I think we discussed briefly about the pathophysiology of multinodular goiters. So there's variable growth, periods of growth versus involution that may lead to formation of nodules. You can see the cut section, the picture on the lower left-hand side, the inside of a multinodular goiter. So all these are colloid-filled nodules. So that is why the thyroid gets much bigger. Earlier people thought this was due to iodine deficiency. What we know is even without iodine deficiency, people can develop multinodular goiters due to various other reasons. One common condition is thyroiditis, chronic thyroiditis. Okay. Assessment. So when somebody comes to the multinodular goiter, we want to know the size, extent, whether the patient has got compression symptoms and whether there's retrosternal extension. We do ultrasound scan, again looking for potential suspicious nodules for malignancy. Then X-ray of the neck may be useful to look for tracheal deviation and compression. FNAC we do either from if there are suspicious nodules or from the largest nodule. No point in doing just a blind FNAC from multinodular goiter. Now, if you go back to the previous picture, you can see there are hundreds and thousands of nodules. So one nodule, a small nodule may be malignant. So therefore, there is no point in doing a blind FNAC from a patient like this. Either you do it from the largest nodule or from a suspicious nodule based on ultrasound scan. Then we do a TSH and if necessary T4 level. TSH if it is euthyroid, no need of T4 levels. CT scan is reserved only for patients with large goiters where there is retrosternal extension or you suspect potential for tracheomalacia, that is thinning of the tracheal cartilages or atrophy of the tracheal cartilages. Okay, so treatment. When do we treat multinodular goiters? We have already discussed one indication, that is toxicity. If the patient has a multinodular goiter and toxicity, then there is an indication. Other indications are whether if the patient has got effects of compression, either symptoms or signs. For example, you can see in this X-ray, the trachea is grossly deviated. So this is a relative indication to do surgery even if the patient is asymptomatic, because we know with time the patient will likely develop symptoms. Same with retrosternal extension. Retrosternal extension, we know there's a high risk of developing complications, effects of compression, and also we have no way of monitoring these patients because retrosternal part can be seen only with a CT scan. So if you are going to monitor these patients, we have to do annual CTs, which is not possible. Therefore, we generally offer surgery for patients with retrosternal goiters. Osmosis is the last indication. If there's no other problem, then we ask the patient, do you like the appearance of your neck? If the patient says no, then it is a balance between having a lump in the neck versus scar in the neck. So if they prefer the scar, we can go ahead with the thyroidectomy. Okay, so multinodular goiter surgery is only treatment. So they are euthyroid, so no need of any medications. The patient has both lobes involved, we straight away go for a total thyroidectomy, provided there's indication to operate. Or only one lobe is involved, they do a hemithyroidectomy, remove only that side with the isthmus. There's no place for medical therapy, that is thyroxine has no place because these patients are euthyroid. Removing the thyroid, starting them on thyroxine will not have any effect. Radioiodine may lead to marginal regression, but not a significant reduction in size. So radioactive iodine therapy is essentially reserved for patients who are not fit to undergo surgery, for patients who do not want to undergo surgery, or patients are coming after multiple surgeries. You know, there's a high risk of potential complications. Those patients may be subjected to radioactive iodine therapy, but it does not work very well for these patients. So it's essentially surgery or no, that's all. Right. Okay. Any questions about management of multinodular goiters?
Sir, you said there is a risk of 10% of them developing malignancies. So, is that an indication to do surgery?
No. What I said was 10% do have malignancies, not that 10% are going to develop malignancies. Right. So, what percentage of normal people have thyroid malignancies? Suppose there are post-mortem studies from different countries. What they are shown is anything between 10 to 50% people do have thyroid malignancies. Normal population. So even if you remove a few of your thyroids, there may be occult malignancy, which will never become clinically significant. That is what we know about papillary carcinoma. A lot of people do have papillary carcinomas, which are never going to become clinically significant. So when you remove the thyroid from multinodular goiter, 10% or 10% or 12% do have these malignancies. It does not mean that multinodular goiter is the reason for this malignancy. It is that it is associated. Now the problem is telling a patient. The patient will ask, doctor, can this be a malignancy? When they come with a multinodular goiter. So it's a very difficult discussion after that. If we say 10%, there's a 10% chance of you having a malignancy, they generally want the thyroid taken out. Right? They are scared. But what we know is thyroid malignancies are most of the time incidental. So there's a small association between multinodular goiters and follicular carcinomas. We will come back to that later. Okay?
Okay, thank you.
I probably have confused you more. I know. Any other questions?
Sir, after hemithyroidectomy, is there a chance of recurrence in the
yes.
other lobe?
The same problem in the opposite side, yes. But of course, advantage is you are reducing the side effects of surgery and also the requirement for lifelong thyroxine. But the downside is if the patient develops multinodular goiter on the opposite side, patient may require surgery at a later date. That's the second surgery. So it's nothing comes with only good effects. Always there are good effects and bad effects. So there is a question, if a patient presents with toxic adenoma and thyroiditis features, those are two different conditions, very unlikely. Any other questions?
So to confirm the retrosternal extension, should we do imaging?
Okay, retrosternal extension is clinical diagnosis. So clinical, if you can't feel the lower pole when the patient swallows, that means there is extension posterior to the sternum or the clavicle. Ultrasound is not a useful investigation for that. So if there's a clinical suspicion, then what we need to do is a CT scan. CT is the only way of confirming retrosternal extension, and that will also tell us how far it is extending retrosternally. Any other questions? Okay, so in the absence of further questions, we'll go into the next topic. We'll discuss. If there's another question. Toxin, what is the best between lobectomy and hemithyroidectomy? Essentially, though we say lobectomy or hemithyroidectomy, they mean the same. In both operations, we remove the lobe and the isthmus, so they are the same. No difference. We use these terms interchangeably. Right. So thyroid malignancies is the next topic. It's a common problem in Sri Lanka. It's one of the commonest malignancies that we encounter. It's second commonest cancer in women. Now this chart shows it's the third. Now over the last couple of years, it has become the second commonest cancer among females in Sri Lanka. So it's very, very common. We see over 1,000 malignancies per year in Sri Lanka, thyroid malignancies. So this is the basic classification of malignancies. You can get malignancies coming from follicular cells, parafollicular cells or C cells or lymphoid cells. Follicular cells, it could be differentiated or undifferentiated. Differentiated is papillary or follicular. Undifferentiated is anaplastic. Parafollicular cells, it's medullary. If it is coming from lymphoid, it's a lymphoma. So there are some of the risk factors. Now this is what I was talking to you earlier also. Radiation exposure risk factor for papillary carcinoma. So if you give radioactive iodine, they have a future increased risk of developing a papillary carcinoma in the future. Autoimmune thyroiditis, they can develop lymphomas or papillary carcinomas. Multinodular goiter, they have high risk of developing follicular carcinomas. And there are genetics. Men syndromes, multiple endocrine neoplasias, they can get medullary carcinomas in 2A and 2B. Werner syndrome and Sippel syndrome. Right. So presentation, how do thyroid malignancies present? They commonest presentation is the nodule in the thyroid, which is typically of recent onset. Sometimes papillary carcinomas come with cervical lymphadenopathy. That could be the first presentation. Change in voice is a potential presentation due to infiltration of the recurrent laryngeal nerve. Pain radiating to the ear, that's a very rare symptom. That is if the vagus nerve is involved. Bone metastasis is typically seen with follicular carcinoma. Sometimes they come with a pathologic fracture. That could be the initial presentation. Not so uncommon in follicular carcinomas. Right. So all those are presentation. Papillary, briefly, it's the commonest. Thyroid malignancy, about 60 to 70% of the thyroid malignancies, even more, are papillaries in Sri Lanka, in most countries as well. Its malignancy is one of the best prognosis. Over 95% 10-year survival. Hardly anybody dies, especially at your age. If you get a papillary carcinoma, you have nearly 100% survival long term. Multifocality is quite common. So if you remember Bailey and Love, there's a picture. So there can be multiple malignancies in the same thyroid. Histology, there are classical features, there are papillary structures, there are what we call orphan nuclei, large empty nuclei, and samoma bodies. You can see it's a calcified, lamellated calcified bodies, or what we call samoma bodies. All these are typical cytologic and histologic features of papillary carcinoma. Papillary carcinoma spread to lymph nodes quite early, cervical lymph nodes. So if somebody has got a suspected papillary carcinoma, lymph node assessment is also mandatory. Sometimes, as I told you earlier, they can present with cervical lymphadenopathy as the initial presentations. Earlier, people used to call this lateral labyrinthyroid, but that is a misnomer. So prognosis depends on age. Age is the most important. Young age or your age is the best prognosis. In small tumor, larger tumor, metastasis, invasion, if you can't remove the tumor completely, then those are bad prognostic signs. Age is the most important. So at your age, irrespective of the size or the status of the, or even if you have metastasis, it's a stage 2 tumor because it's completely curable. Right. Then follicular carcinoma is slightly different. It's slightly older population. Papillaries are typically in 20 to 40 age group. Folliculars are probably 30 to 60 age group. Histology, you can see there is what you call important thing is vascular and capsular invasion. So with the FNAC, you can't diagnose a follicular carcinoma. You can see it's only follicular neoplasm. Now the arrow shows the capsule is being infiltrated. You can see the capsule, the light pink areas are the capsule and the tumor going through the capsule. So if you see this is a follicular carcinoma. If that is not there and the capsule is continuous, then it is a follicular adenoma. So you can see this only with the histology. Earlier people use assessment is also mandatory. Sometimes, as I told you earlier, they can present with cervical lymphadenopathy as the initial presentations. Earlier people used to call this lateral labyrinthyroid, but that is a misnomer. So prognosis depends on age. Age is the most important. Young age or your age is the best prognosis. In small tumor, larger tumor, metastasis, invasion, if you can't remove the tumor completely, then those are bad prognostic signs. Age is the most important. So at your age, irrespective of the size or the status of the, or even if you have metastasis, it's a stage 2 tumor because it's completely curable. Right. Then follicular carcinoma, it's slightly different. It's slightly older population. Papillaries are typically in 20 to 40 age group. Folliculars are probably 30 to 60 age group. Histology, you can see there is what you call important thing is vascular and capsular invasion. So with the FNAC, you can't diagnose a follicular carcinoma. You can see it's only a follicular neoplasm. Now the arrow shows the capsule is being infiltrated. You can see the capsule, the light pink areas are the capsule and the tumor going through the capsule. So if you see this is a follicular carcinoma. If that is not there and the capsule is continuous, then it is a follicular adenoma. So you can see this only with the histology. So prognosis is slightly worse than papillary. Multicentricity, less common. Generally, these are single nodules and lymph node deposits or lymph node metastases are quite rare with a follicular carcinoma. They typically spread through the blood-borne route. So they go into bone, liver, lungs are the common site. Bone is a commonest site. Right. So if somebody comes with a differential thyroid carcinoma, so the confirmation will be with a ultrasound and a fine needle aspiration, then how do we treat? So treatment is primarily surgical. Irrespective of the stage of the disease, we do a thyroidectomy. Most of the time, it's a total thyroidectomy. Advantage is now, the question is, if only one side of the thyroid is involved, why do we need to remove the whole thyroid? It's like removing both breasts for a malignancy of one breast. So we remove it because that facilitates radioactive iodine, which is one of the most important adjuvant therapies. Because if we remove only one side of the thyroid, we cannot give radioactive iodine. And also thyroglobulin follow-up, which is a tumor marker. We cannot use thyroglobulin as a follow-up, a tumor marker, if we don't do a total thyroidectomy. That is why in most situations we do a total thyroidectomy. But the disadvantage is patient will have a risk of more complications and the need for lifelong thyroxine. Therefore, if the patient has a very low risk tumor, like a tumor that is less than a centimeter, generally what we do is a hemithyroidectomy or a lobectomy. That is enough because those patients will not require radioactive iodine or stringent follow-up with thyroglobulin as the tumor marker. So in addition to the thyroid, if the lymph nodes are involved, we need to remove these lymph nodes surgically prior to giving radioactive iodine. So that is how we treat these differentiated thyroid cancers surgically. And then following surgery, if the tumor is big enough or if there are risk factors, we send the patient for radioactive iodine ablation. Here what we do is once we give the radioactive iodine, if there's any residual thyroid malignant cells, those will take up radioactive iodine because the normal thyroid is no longer there, and then those will be destroyed with the action of iodine. That is the idea of giving radioactive iodine. In addition to that, we can keep TSH suppressed by giving high doses or so what we call supraphysiological doses of thyroxine. It is just like giving something like tamoxifen for a patient with breast carcinoma. There what you do is you just block the effect of estrogen and progesterone on the tumor. Here we do the same. Because these are differentiated tumors, they have a risk of coming back with the effect of TSH. So if you can keep the TSH suppressed, then you can minimize the risk of this tumor coming back. So those are the standard treatments. We do surgery followed by radioactive iodine therapy and TSH suppression with supraphysiological doses of thyroxine. Not for all patients, depending on the risk. Radiation, external beam radiotherapy may be given for patients with extremely advanced disease with multiple other structures involvement, or if you can't remove the tumor completely, then external beam radiation is an option, but again, not a routine treatment. Other treatments like chemotherapy have no effect. So therefore, we don't give chemotherapy for thyroid malignancies. Right. So those are the differentiated thyroid malignancies coming from follicular cells. The undifferentiated one is called anaplastic. Luckily, it's a very rare malignancy, which you typically see in old patients. They come with a rapidly advancing or rapidly growing thyroid nodule, maybe fixed with difficulty in breathing, difficulty in swallowing, etc. And once you confirm the diagnosis, maybe with a co-biopsy, treatment is palliative. Whatever you do, almost 100% of them will die within a year. So it's one of the most aggressive malignancies known to humans with a very poor prognosis. Typically, you see this very rarely only in old people. Young people don't get anaplastic carcinomas. Management is only palliative. Right. Medullary carcinoma, it's slightly different. It comes not from follicular cells, but from the parafollicular or C cells, which secrete calcitonin. So the presentation again, a thyroid nodule, or they can have features of what you call due to excessive secretion of serotonin, prostaglandins, like diarrhea. This is quite rare, fortunately. Again, there are different risk factors. Some are sporadic, the commonest variety. Others could be familial or could be related to multiple endocrine neoplasia syndromes, what we discussed previously. So this is far more aggressive than the differentiated thyroid cancers we discussed previously. These tend to spread to other lymph nodes and metastasis quite early. And because these are not follicular cells, they don't respond to radioactive iodine. Chemotherapy also has very little effect. So therefore, surgery has to be quite aggressive. Therefore, always you do a total thyroidectomy, maybe with prophylactic lymph node removal. But still, they have a fairly poor prognosis compared to the very good prognosis that you see with differentiated thyroid cancers. Right. So thyroid cancers prognosis generally, if you think of different follicular and papillary, stage 1 and 2, almost 100% survival. Overall survivals we discussed previously. Papillary I told it's over 95%, follicular slightly low, medullary even low, anaplastic nearly 0, 5-year survival. Right? So there's a big difference in the survival rates among these thyroid malignancies. Okay, so that brings us to the end of thyroid malignancies. Any questions? Any questions on malignancies? We discussed about differentiated thyroid malignancies, that is papillary and follicular, then anaplastic, undifferentiated, medullary. Those are the 4 different types of thyroid malignancies we discussed. Do you have any questions on diagnosis, treatment, follow-up, etc.?
So since the follicular malignancies can't be diagnosed within, from an FNAC, how can it be?
Okay, so when somebody comes to the nodule, let's say follicular carcinoma, the FNAC cannot differentiate whether it's a carcinoma or an adenoma. FNAC will say Ty3 or Bethesda 4. It can say it's a follicular neoplasm. So the next step is to do a diagnostic hemithyroidectomy. We remove half of the thyroid and send it for histology. Then if the histology shows this capsule and vascular invasion, then we go ahead and remove the opposite side, or what you call completion thyroidectomy. Because without doing a lobectomy, we cannot conclusively say this is a follicular carcinoma. Even a co-biopsy is not enough, because you saw only in a small area you might see the capsular vascular invasion. So without looking at the whole nodule, we cannot conclusively say whether it is benign or malignant.
Thank you, sir.
Right. Co-biopsy in thyroid cancer. Right. Co-biopsy has got a couple of indications. One is anaplastic carcinoma. If you suspect anaplastic, then you can do a co-biopsy, confirm the diagnosis, and send the patient for palliative care. If you suspect a thyroid lymphoma, I skip that topic, not very important for you, then that is another indication for doing a co-biopsy. Third, now in some countries, even for other malignancies they do, but not in Sri Lanka. So if you remember, co-biopsy is done only for anaplastic and lymphomas, that is enough. So one question is, are both FNAC and co-biopsy required in the diagnosis of anaplastic carcinoma? Not required. Generally what happens is we initially do FNAC. FNAC we might show highly differentiated or poorly differentiated malignancy. So then we may do a co-biopsy to confirm the diagnosis definitively, because in anaplastic we decide not to operate and manage the patient palliatively. So for that, it's better always you have a histological diagnosis. Okay, so another question, follow-up of differential thyroid malignancies. Do we use thyroglobulin? Yes. So follow-up of follicular and papillary carcinoma, provided they have undergone total thyroidectomy. Then what we do is we do annual thyroglobulin levels. So thyroglobulin after thyroidectomy, we wait for 6 weeks and we do a thyroglobulin level. It should be undetectable, provided we have removed the gland completely. It's just like CEA levels after colorectal malignancies. Then annually we do thyroglobulin levels. As long as they remain undetected, we are happy. There's no tumor recurrence. But if it starts going up, then we know there's potential for potential recurrence. Then we do further imaging to detect where the recurrence is and manage accordingly. So it is useful for both papillary and follicular. For medullary carcinoma, tumor marker is calcitonin. We do a calcitonin level annually to look for a recurrence. Again, it should be undetectable in circulation. If it is increasing, then we know there's a recurrence. So do we need to make the patient hypothyroid before starting on radioactive iodine therapy? Yes. For now, after total thyroidectomy, we need to ensure when you give the radioactive iodine, there is maximum uptake. So you want to ensure all the remaining malignant cells are really starved of iodine. So we can do that by stopping the thyroxine for a period of 3 to 4 weeks. So the TSH stimulation is maximum. By stopping thyroxine, you can ideally the TSH level should be over 30 before giving radioactive iodine. You don't have to remember these. So thereby, when you give the radioactive iodine, you ensure maximum uptake by whatever the remaining malignant cells. So one question, if the FNAC shows follicular neoplasm, standard management, unless the patient has got metastatic disease, in which case, this is definitely carcinoma, standard management is a hemithyroidectomy or lobectomy. We use the terms interchangeably. Essentially, what we are doing is we remove the lobe and the isthmus as a diagnostic procedure. Then based on histology, if it shows an adenoma, no more surgeries. But if it shows a carcinoma, in most situations, we go ahead and remove the opposite lobe or whatever completion thyroidectomy. Why did I say in most situations? If the tumor is very small, less than a centimeter, we may not do it. That is right. But otherwise, almost always we go ahead and do a completion thyroidectomy. Right. So now the last topic, thyroiditis. Thyroiditis is inflammation of the thyroid gland. So typically we describe 3. Acute, that the patient comes with very short duration acute inflammation of the gland, or subacute, slightly less, it's over a couple of weeks, or chronic thyroiditis, where the patient has had symptoms of going on for months and years. So these patients present with different symptoms. They may come with a goiter, that is enlargement of the gland, pain due to inflammation. Pain may be associated with other symptoms like odynophagia, difficulty or painful swallowing. Plus, they may have features of thyrotoxicosis or hypothyroidism. We'll discuss in which conditions they get these symptoms. So acute thyroiditis is a very rare condition. Typically, it's an infection of the gland, and bacterial typically with suppuration, very rare. So I will skip that. Much more common is what we call subacute thyroiditis or decurvent thyroiditis. Here what happens is it is typically secondary to upper respiratory tract infection, a viral upper respiratory tract infection. Patient gets a respiratory tract infection. A couple of weeks later, patient comes with a painful enlargement of the thyroid gland associated with difficulty in swallowing, maybe what we call odynophagia. Plus, they may have features of thyrotoxicosis, not hyperthyroidism. Thyrotoxicosis, there is destruction of the gland with resultant release of thyroxine into the circulation. So they may be tachycardic, they may be having increased sweating, diarrhea. All these symptoms may be there in these patients. When you do biochemical assessment, you find increased reduced TSH and elevated T4 and T3 levels because there is increased release. In addition to that, because these are autoimmune, there can be elevated thyroid peroxidase antibody levels, and typically CRP levels are also going to be high because it's post-infective. So once the diagnosis is made, most situations the clinical diagnosis, management is just conservative or palliative. Conservative, not palliative, conservative. We give them some painkillers and maybe some immunosuppressants, and the disease will go away within a couple of weeks because it's a post-viral reactive condition. And in a couple of weeks, the disease gets better on its own. So most of the time, they do not require treatment. Only thing that we might have to do is give them some NSAIDs and glucocorticoids, that is steroids. Right. Then other condition, much more common condition, what you call Hashimoto's thyroiditis or chronic lymphocytic thyroiditis. Here what happens is it's an autoimmune condition. There is gradual and progressive destruction of the thyroid due to presence of autoantibodies, lymphocytic autoantibodies. Much more common in females than males. The presentations include a small goiter, typically a rubbery or a firm goiter, which is not very big. Typically, it's a small goiter. And typical presentation is hypothyroidism. Although early stages, they can have marginal toxicosis, or what you call hashitoxicosis, it is quite rare. The more common thing is they become gradually hypothyroidism. So management essentially confirmation of diagnosis clinically plus ultrasound shows typical features of chronic thyroiditis, and FNAC might confirm that. Thyroid peroxidase antibodies are almost always positive in these patients because it's autoimmune. And the management essentially is to follow them up. Unless the patient is hypothyroid, you have to start them on lifelong thyroxine. If the patient is already not hypothyroid, you know the patient has a fairly high risk of hypothyroidism. So you need to follow them up annually with a T4 TSH level. From the time they become hypothyroid, you need to start them on thyroxine. It's a very common condition in Sri Lanka nowadays, especially among females. Though I have said, age I have not mentioned. Typically, this is starting from the age 30, 40 onwards. But nowadays, we find fairly high proportion of females in their 20s or late teens even developing chronic thyroiditis and hypothyroidism. A fair number of medical students are already on thyroxine because they are hypothyroid. There may be others who are always falling asleep, etc. So I recommend that you get a T4 TSH level if you feel that you may be hypothyroid, because it's a fairly common condition in Sri Lankan population, chronic thyroiditis and hypothyroidism due to as a secondary effect. Some people believe this is due to excessive thyroxine in our diet or the salt that we take, but it has not been proven. So here what happens is there are antibodies, and these antibodies attack thyroid cells coming from the plasma cells or lymphocytes, and then there is a gradual and a progressive destruction. Unlike in other goiters, these goiters typically don't get very big. So generally we don't have to do a thyroidectomy. So most of the time we can manage conservatively. Only thing they will require is medical thyroxine if the patient is hypothyroid. Okay, so that is about thyroiditis. So we discussed about three conditions. Acute, which I didn't discuss, then subacute, that is liquor veins, post-viral, and chronic thyroiditis, which is Hashimoto's thyroiditis. Hashimoto's thyroiditis is a risk factor for development of thyroid lymphoma. What they say is more than 50% of the patients with thyroid lymphomas do have a history of chronic thyroiditis. In addition to that, chronic thyroiditis may progress to papillary carcinomas as well. So the risk is not that great. Okay, any questions?
So do we perform thyroid peroxidase and antibodies in all suspected patients with thyroiditis?
Okay, it is like this. You may do it, but most of the time it is not going to change your management. Because what we discussed the management was, if you have a confirmed diagnosis of chronic thyroiditis, you do, if the patient is already hypothyroid, you start them on thyroxine. Otherwise, you annually follow them up with T4 TSH. And as and when they become hypothyroid, we start them on thyroxine. So whether we do thyroid peroxidase levels or not, it's not really going to change our management. But if you really want to confirm your diagnosis, it is helpful in some situations.
So in liquor veins, thyroiditis, for how long do we expect the symptoms to?
Typically a couple of weeks, but it can go for a couple of months. Not more than that. Very rarely only they will go for more than 3 months.
Thank you.
So though they become toxic, generally we don't start them on antithyroid medications like carbimazole because we know it's a self-limiting condition. Hashimoto's thyroid associated other autoimmune conditions, yes, like Graves' disease. Hashimoto's also can be associated with other conditions, but not as common as in Graves' disease, because in most patients what they are describing is this is related to local thyroid problem rather than a generalized autoimmune problem. Any other questions? Okay, so in the absence of further questions, we'll just go back to our case scenarios that we gave you at the beginning. So patient, if you remember the young girl who presented with features of Graves' disease. So what should we do? Can somebody answer? So don't worry, I can't see you, so I won't know who's answering. Anybody wants to give it a go? Management of patients with Graves' disease, this girl?
We can start her on carbimazole. Initial high dose, and then we can continue carbimazole until her symptoms, until she becomes asymptomatic.
Then what should we do? Anybody else want to give it a try?
We can start this patient on high dose carbimazole, and in 6 weeks to 2 months time, we can repeat the thyroid profile and see whether the thyroid functions are in the normal range. And if that's the case, we can see whether there will be another relapse. If there isn't, we can say that this patient is cured. If not, we can again start on carbimazole and go for a surgery.
So what we need to do is, you're correct. So we start the patient on carbimazole high doses, maybe 45 or 60 milligrams daily with propranolol, because you can see she's quite symptomatic. So propranolol will give initial symptom relief. So then we will see her in a few weeks time, maybe 6 to 8 weeks time with repeat T4 TSH. By that time, if the symptoms are controlled, we can stop propranolol and reduce the dose of T4 TSH depending on the response. Then we need to continue carbimazole gradually tailing off with a maintenance dose up to a minimum of 6 months to a maximum of 18 months. Then we can stop the medication and see if the patient disease doesn't come back, she's cured. If the disease comes back, we know this is carbimazole dependent Graves' disease. So then we have to start carbimazole again and go for definitive either radioactive iodine therapy or surgery. Okay, but of course there are exceptions if he doesn't respond, what to do, those things we discussed. But provided it's a straightforward case, that is how we would manage. Right. Next one. This is a toxic multinodular goiter. How should we manage? Anybody want to try?
Make the patient euthyroid by giving thyroid medication. And once the patient is euthyroid, follow it up with thyroidectomy.
Yeah. So similar to previous one, we start on carbimazole plus or minus propranolol. So then once the patient is controlled, we offer patient either radioactive iodine or surgery. So it depends on patient preference, availability, cost, and various other things, size of the goiter. We discuss all those. Based on that, we offer either radioactive iodine or surgery. In this patient, you can see the goiter is pretty small. So certainly he has the option of going for radioactive iodine therapy provided it is available. And we know the advantages and disadvantages of each of the treatment modalities. Right. Next one. This is a patient with multinodular goiter. What should we do?
She needs to undergo a total thyroidectomy. And then start her on thyroxine replacement.
Yeah. So we need to do a TSH to confirm that she is euthyroid. So if that is there's an indication for surgery here, which is relative, of course. There's significant tracheal deviation. So therefore, we need to offer her a total thyroidectomy, and then she'll have to be on lifelong thyroxine treatment. Okay, this one with suspicious nodule in the thyroid, suspected to be a malignancy. FNAC comes at T5. Let's say, what should we do? 4 centimeter nodule.
Total thyroidectomy.
Then?
Followed with lifelong thyroxine treatment.
What else?
Radioactive iodine therapy.
Okay, what else?
Surgery.
Follow up with thyroglobulin.
Okay, what else? So she should undergo total thyroidectomy, followed by radioactive iodine treatment and suppressive thyroxine therapy, and annual follow-up with thyroglobulin as the tumor marker. So those are the steps in management of this patient. Right. Okay, any questions? Any other question? Anything else you want to ask? Right. So since you have got, somebody's raising his hand. Yes, Imhan. Oh, is it a mistake? Right. Since you have got some time, we'll go through a few MCQs. These are from some of your past papers. I will give you a minute to read the question and then tell me the answers. Okay. So, which of the following statements regarding papillary thyroid carcinoma are true? First one, is it true or false?
True.
First one is true. Yeah, I told you majority of the papillary carcinomas are papillary. Then what about the second one? Ipsilateral lobectomy is adequate for micropapillary thyroid carcinoma. Micropapillary is when it is less than a centimeter in size.
True, sir.
Yeah, that again is true. Microscopic evidence of multicentric disease is present in 7 to 80% of cases. So again, if you read your Bayesian law, that is what it says. It says about 70% do have multicentric disease in papillary carcinomas. That is more than one focus of tumor. Then fourth one.
True, sir.
So I told you, if you get a papillary carcinoma, it's very good prognosis. Whereas if older person gets a papillary carcinoma, it is not so good. What about the last one?
False.
Yeah, it's obvious false. It's much more common in females than males, like all other thyroid conditions. Right. Advantages of total thyroidectomy for management of a 1 centimeter papillary carcinoma of the thyroid versus a lobectomy include. What do you think of the first one? Possibility of using radioactive iodine post-operatively?
True.
It's true. Ability to use thyroglobulin levels as a tumor marker? True. Lower overall recurrence rate?
True.
That is true. There's a slightly lower risk of tumor recurrence. Yeah. Lower risk of hypoparathyroidism?
False.
So we are operating on both sides. There's a much higher risk of hypoparathyroidism. Then recurrent laryngeal injury?
False.
That's again false because we are operating both sides. So the risk is essentially double. Right. 3 easy questions. Right. Which of the following statements about follicular carcinoma are false? False, huh? Associated with multiple endocrine neoplasia syndromes. Okay, shall we make that? This is a double negative, no? So it's difficult. We'll say which of the following statements about follicular carcinoma are true? We're killing the question because it's a bad question. Is associated with multiple endocrine neoplasia syndromes. Is it true or false? Is it true or false? False. Follicular is not follicular carcinoma. It's a medullary carcinoma. It disseminates by hematogenous route.
True.
I told you sometimes the initial presentation of a follicular carcinoma could be bone metastasis. It is the most common type of well-differentiated thyroid carcinoma. False. It is papillary carcinoma. This is less common than papillaries. Extensive angio-invasion is a poor prognostic factor.
True.
It is true. Angio-invasion means the tumor inside blood vessels. So once the tumor goes into blood vessels, the risk of tumor spreading to other sites in the body is much greater. Therefore, extensive angio-invasion is a much poor prognostic sign compared to maybe capsule invasion. Follicular carcinomas are frequently multicentric. False. We know it's a papillary that is multicentric. Folliculars are not multicentric in general. This is SBA. 28-year-old woman presents with a 3 centimeter solitary nodule of the right lobe of the thyroid. 5-needle aspiration cytology shows that he is suspicious of papillary carcinoma. What is the most appropriate next step? O biopsy, radioisotope scan, repeat FNAC, right hemithyroidectomy, total thyroidectomy.
Total thyroidectomy.
Any other answers?
Right hemithyroid.
Sorry?
Right hemithyroidectomy.
Right hemithyroidectomy. Anything else? Repeat FNAC. Anybody for repeat FNAC? Radioisotope scan. Okay, so I can't see how many you want to answer for particular ones. Okay, so the answer is total thyroidectomy because now if you read the book, what it says is if the report comes as type 5, over 90%, 95% of the possibilities that it is a malignancy. If it comes as type 4, it's about 75%, 75 to 80% possibility that this is a malignancy. So we still consider this as a malignancy and treat. Therefore, we don't do a hemithyroidectomy because if you do a hemithyroidectomy, 80% of the time, you will have to go back and remove the opposite side because this is a fairly big tumor, 3 centimeters. So the standard treatment in a situation like this is a total thyroidectomy. Right? But we know that 20% of the time, it may not be a malignancy. But that is what we need to do because even if you repeat the FNAC, what if the next step FNAC comes as benign? Can you just leave it? No. So therefore, we need to go ahead and do the surgery. Okay. Any other questions? So I think that brings us to the end. So what I will do is in your Google Classroom, I will post the SCQs. Your batch prep has sent me the SCQs. So I will post one SCQ at a time. There are about 3 or 4 SCQs. So you can take half an hour. That's the standard time. And not even half an hour. You can take about 10 minutes and write the structure of your answer. I think some of the groups I would have discussed how to plan the structure. No, just write a summary and send me the answer. So I will give the feedback. Okay.
Okay, sir.
Any other questions? Okay, there are 2 more questions. What is the place of monitoring pH and calcium levels after thyroidectomy? Okay, I think most of these we have discussed during the appointment. We do not monitor PTH because PTH is a very expensive investigation which is not available routinely. Ideally, we should do calcium levels after surgery. So in ideal situation, we should do PTH. But if not PTH is not available, we need to do calcium. But unfortunately, in National Hospital, both are not available every day. Calciums are done only a couple of days a week. So we don't do either. Right? Ideally, one or both should be checked to see whether the patient is developing hypocalcemia, in which case you need to start treating them. Is there a significant risk of developing thyroid lymphoma in patient with Hashimoto's thyroid? No. What I said was 50% of patients who develop thyroid lymphomas do have a history of thyroiditis. That is 50% of thyroid lymphomas. But thyroid lymphoma is a very, very rare thing. Right? I don't think any of you have seen. I have seen about 2 during my lifetime. So it's a very rare condition. So therefore, we do not monitor patients with thyroiditis for thyroid lymphomas. Right. So there's another question. Is the management of patient presenting with hypocalcemia following thyroid surgery? So hypocalcemia, it depends on the severity of hypocalcemia. If it is symptomatic, we initially give them calcium gluconate intravenous followed by oral calcium carbonate and 1/2 calciferol, that is vitamin D, and gradually take it off. About 30% of patients develop temporary hypocalcemia after thyroidectomy, total thyroidectomy, but only about 2% are permanent. So majority, we can stop the calcium supplementation within a few weeks. Others need to continue lifelong. Any other questions?
So what is the commonest cause for stridor after thyroidectomy? Is it the laryngeal edema, or is it just reactionary bleeding cause the stridor?
It depends on the surgeon, I would say. If the surgeon is very good and cuts a recurrent laryngeal nerve regularly, then it is going to be recurrent laryngeal nerve palsy, right? If the surgeon does not achieve hemostasis and regularly leads to hematomas and laryngeal edema, then it is going to be laryngeal edema. So you can't say, but this is the commonest. So it depends on the indications, because if the surgeon is a surgeon who operates recurrent goiters or advanced malignancies, then likely be recurrent laryngeal nerve palsy. Right? Otherwise, it's hematoma and laryngeal edema.
Okay, sir. Thank you, sir.
It depends on the timing. So more important thing is the timing. So if it is immediately after surgery, as soon as the patient is extubated, we know it's likely to be a laryngeal nerve palsy. Whereas if it happens a few hours after the operation, it is likely to be bleeding and laryngeal edema.
So can bleeding alone cause a stridor, or does the bleeding has to cause the laryngeal edema to cause the stridor? Like if we are asked, what is the cause for stridor out of those two, out of laryngeal edema and
now the bleeding 2 types of vessels. No, bleeding can be from veins or arteries. So let's say there is venous bleeding, there will be collection of blood inside the pretracheal fascia, but it will not exert any pressure. So there won't be any impairment of venous drainage from the larynx, or neither there would be any compression of the trachea. So there is bleeding, but patient will not develop stridor. Whereas it is arterial bleeding, it's a high pressure bleed. So gradually there will be build-up of pressure inside the pretracheal fascia. So that will impair venous drainage from the larynx. Plus it will exert some degree of pressure effect on the trachea itself, mechanical pressure. So that can narrow the larynx, as well as laryngeal edema will further narrow. So I don't know the answer to your question. Bleeding alone, venous bleeding will not. So it is bleeding causing pressure.
Yeah. Okay, sir.
Any other?
Okay, sir.
Any other questions? No? Okay, one more. What is the commonest cause of hypocalcemia after total thyroidectomy? Okay, ischemia of parathyroid gland or parathyroidectomy. Parathyroidectomy is operation. This should be accidental removal. It again depends on the surgeon. Most of the time, I told you, 30% of the time it's temporary. So if it is temporary, it should be ischemia. If the gland had been removed, it should be permanent. So hypocalcemia after surgery, in most situations, more than 90% of the time is due to ischemia of the glands, temporary dysfunction, which recovers after a few weeks. That is why we give calcium supplementation for a couple of weeks and then we can stop. Maybe about 2% only, or 2 or 3% only will go on for lifelong calcium supplementations. Right. Okay. So in the absence of further questions, we'll call it a day. So I will, okay, one more question, probably this is the last one. So what is the significance of third generation of TSH assay? Okay, I think these we have discussed during the appointment. It's the sensitivity of the assay. If you read your physiology, first generation and second generation limited sensitivity. That is a lower mark, a lower cutoff. So third generation means up to 3 decimal points, 0.004. You can assess the thyroxine level. So it is very sensitive, and you can easily diagnose a patient, whether the patient is hyper or hypothyroid based on a TSH assay alone. So there is no indication for doing T4 and T3 levels if you're just screening somebody to detect whether the patient is hyper or hypothyroid. Whereas if the patient is already hyper or hypothyroid, you have to do both TSH, which will confirm the thyroid status, plus T4 levels, which will assess the severity. Right. So I will post the essay questions maybe one at a time or several weeks. You probably will have about 3-4 weeks, and we'll try to discuss those questions and find the answers. Okay, probably the last question coming up. Okay, that's a thank you, sir. Right. Okay, it's not a question. Right. Okay, thank you very much, guys. I think hopefully you got something out of the CLD. If there are any questions, probably you can email them to me, or you can post them in the Google Classroom, and I will post the questions, the SCQ questions there. Right. Okay. Enjoy the rest of the day.
Thank you, sir.